Everyone, welcome back to my channel. Thank you for following my page. Thank you for subscribing to my YouTube channel. I'm back again. Today we'll be talking about hyperemesis gravidarum. Hyperemesis gravidarum is a medical term for excessive and persistent nausea and vomiting in pregnancy associated with dehydration, ketosis, electrolyte imbalance, nutritional deficiency, and weight loss greater than 5% of the pre-pregnancy stage. Now, pre-pregnancy weight, if you start vomiting to the extent that we have these things I mentioned, dehydration, ketosis, electrolyte imbalance, nutritional deficiency, you vomit, you cannot take back, and you lose your weight more than 5% of what your weight was before you got pregnant, you have hyperemesis gravidarum. It affects about 0.5 to 2% of pregnant women. It's not that common because the normal pregnancy vomiting, which we call morning sickness, that we know, the one we commonly know, morning sickness, affects about 70 to 80% of pregnant women. So hyperemesis gravidarum it happens, but it's not that common. Now, it starts from 4 to 7 weeks of pregnancy. In fact, immediately you are missing your period, person will start vomiting. It peaks around 10 to 11 weeks of pregnancy, and it subsidies around 16 to 18 weeks of pregnancy. When I see my patients and they present with hyperemesis gravidarum, I counsel them that be calm. As we are managing you soon, it will be over, because it's expected that after 18 weeks there should be nothing like that. Any vomiting that starts around 10 weeks, severe vomiting, excessive and persistent nausea and vomiting that starts around 10 weeks and continues throughout pregnancy, is not hyperemesis gravidarum, should be investigated for other causes of that vomiting. So hyperemesis gravidarum are this. Now, pathogenesis. What we think are the cause. Hyperemesis gravidarum is a disease of theory because we have not placed our hand on a particular cause that is, we can say this is the cause of hyperemesis gravidarum. So that's why we call it disease of theories. We have postulated theories have been postulated to be the cause of hyperemesis gravidarum. One, we know there's one we call hormonal theory. Another is food theory. Another one is psychological theory. Another one is Helicobacter pylori infection theory. And the last is serotonin uptake theory. Now, I'm going to deal with this. Now, let me take it in as much as possible how we are going to understand it. In hormonal theory, it's postulated that increase in the hormone of pregnancy, which is beta human chorionic gonadotropin, that is beta HCG, is what causes hyperemesis gravidarum. Why is this said? Because we have found out that in abnormal pregnancies where these hormones are excessive, like in molar pregnancy, gestational trophoblastic disease, there's a one we call molar pregnancy. You will not see a baby, but there's pregnancy going on, and the pregnancy is usually bigger than the age. So in this type of pregnancy, their beta HCG is very high, and so some of these women will not come with hyperemesis gravidarum. So it's postulated from this theory that beta HCG could be a cause of hyperemesis gravidarum. Also in pregnancies with trisomy, these women, trisomy 21, these women are it's postulated that it could be the reason for hyperemesis gravidarum. So any woman that is vomiting excessively, so the theory states that the cause is from beta HCG. Other ones that has been said to be, other hormones that have been implicated include estrogen, progesterone, and others. So remember I told you it's a disease of theory. The second one is psychological theory. Psychological theory is, for people that are affected psychologically, small thing affect them psychologically, expect them to have hyperemesis gravidarum when they are pregnant. Because, for example, those that have hysteria, those that always need attention, even when they are not pregnant. Normal childhood dependence effect in someone, expect them to have hyperemesis gravidarum, because mainly they find out they are pregnant, psychologically inbuilt, they already know that there's vomiting will occur, and so their own may become excessive. The third is Helicobacter pylori infection theory. It's been noted that those with Helicobacter pylori is what causes what we call ulcer. Those that present with ulcer even before pregnant tend to vomit. So when they are pregnant, it becomes excessive. So if you are screening a woman for hyperemesis gravidarum, please also screen for Helicobacter pylori infection. It could be because of that hyperemesis gravidarum. And for such patients, treatment with antibiotics and proton pump inhibitor reduces the hyperemesis gravidarum to the barest minimum. The next one is food theory. It's postulated that people in areas where plant-grown food like yam, legumes, rice, maize, cassava are more consumed than animal-based food, they tend to have less hyperemesis gravidarum than those that consume mostly animal-based food. That's the basis for this theory. The other one is serotonin uptake inhibitor theory. Now, risk factors. Risk factors for developing hyperemesis gravidarum. Age. The younger women, less than 35 years, they tend to have higher risk for hyperemesis gravidarum. Those that is their first time of getting pregnant, we call it primigravidas or nulliparity, is a risk factor for hyperemesis gravidarum. Those that have multiple gestation, more than one babies in the uterus, is a risk factor for hyperemesis gravidarum. Those that have abnormal pregnancy, like I've said before, molar pregnancy, trisomy 21 pregnancy, is a risk factor for hyperemesis gravidarum. Now, other risk factors include those that are psychological, like we've said, those that are intolerant to oral contraceptive pill. If you've ever taken oral contraceptive pill and you do not tolerate it, you are at risk of hyperemesis gravidarum. Those with migraine before are at risk of hyperemesis gravidarum. Previous history of hyperemesis gravidarum. If you have in your previous pregnancy you vomited, you had hyperemesis gravidarum, it's possible that you will vomit again. Previous family history, even if for someone that is above 35 years and you are still vomiting excessively, it's possible that there's family history. Then pregnancy with female babies, we are strong. We do great things. So women with pregnancy that is female babies, they tend to have hyperemesis gravidarum. These are some of the risk factors for hyperemesis gravidarum. If someone presents with hyperemesis gravidarum in the hospital, there are things we do. We take a history. From the history, we'll find out if we can classify whether it's just normal morning sickness or vomiting in pregnancy or hyperemesis gravidarum. We take a history, we examine the person. Examination will show, dryness of the tongue, dryness of the mouth, will show that this person is dehydrated. Loss of skin turgor. You pull this skin, it's supposed to go, but see my own. I'm dehydrated very well. But if it's someone that is dehydrated, it will take time before this thing I'm pulling will go back. So loss of skin turgor is a sign of dehydration. Now, other things we can now do investigation. Find out your electrolyte. First thing we do is serum electrolyte and creatinine. We'll find out the electrolytes that are deranged. There could be hyponatremia, there could be hypokalemia. This should be corrected. Now, they are prone to electrolyte derangement. If I start rehydrating the patient, it's expected that ketosis, because you're going to do urinalysis, and there will be presence of ketosis. It's expected that the ketosis will be out of the system in 2 days, in 48 hours. But if it's persistent, you should screen the woman for another thing that may be the cause for hyperemesis gravidarum. So when you do a packed cell volume, they usually have hemoconcentration because of dehydration. But when you correct it, it will go back to normal and make sure that this woman is being anemic. That what you are getting as elevated packed cell volume is actually hemoconcentration. Ultrasound may also be done. Then, when this is done, we start managing the person. We can treat the person. Normal emotional support gives even better results. Just emotionally counsel them on what they are having and give them emotional support they need. The husband should be there to give much support as possible, as much as possible. That's not the time to start quarreling the person. That's not the time to start telling the person that you are feigning it, that this thing you are is, what about the other woman that is pregnant? Why is your own different? No, that is not the time. Give them as much as emotional support. It will even solve half of the problem. Then if the person cannot take, if the person can take small feed per time, give them small feed. Let them not take much. Whatever that irritates them, if this food that they don't like, that when they see this food they start vomiting, please don't give them that food. Remove that food from there as much as possible. If need be, admit. In fact, hyperemesis gravidarum requires hospitalization. So with hospitalization, you'll be doing this thing I said. Now if you're going to rehydrate, set up an intravenous line and rehydrate them. Rehydrate them very well. If you are going to give dextrose containing fluid, please give thiamine to avoid menicare encephalopathy. These are the complications that may follow. So as you continue to correct, some of them will even require parenteral nutrition. So patient is managed based on her presentation. Treatment is actually divided into pharmacological and non-pharmacological methods. So if you are going to use a non-pharmacological method, feed small as tolerated. The person should delay brushing, early morning brushing, delay it to when the noon time. It will help. Then other things you can do is let the person take high carbohydrate meal, intermittent, small feed of high carbohydrate meal. Those use of high carbohydrate drinks like Coke, Fanta, something that is high in sugar content is better than ordinary water in those that have hyperemesis gravidarum. So you can use those in place of water during meals. Other things that have been found to be useful is use of garlic powder, or even use of putting garlic in your mouth to chew. It helps stop and prevent, or even to help you reduce hyperemesis gravidarum. Now, pharmacological means are the ones of setting up an IV line, intravenous fluid, giving intravenous fluid to correct dehydration, remove ketosis, correcting with potassium for those that have hypokalemia, then use of antiemetic drugs that stop vomiting can be very important, and support, emotional support, counseling is much important. Now for those that are extreme, give parenteral feed, can give parenteral nutrition, put NG tube and feed them with it. It will help a lot. Hyperemesis gravidarum has complication. The complication could be maternal and it could be fetal. It can lead to miscarriage if not well managed. It can lead to stillbirth, intrauterine growth restriction, and even fetal death. So hyperemesis gravidarum can even lead to congenital anomaly in the baby, like musculoskeletal and structural abnormalities. Even some studies have associated hyperemesis gravidarum to testicular cancer in male fetuses. So it has complication on the baby. Complication on the mother, electrolyte imbalance, Mallory-West syndrome. There is tear, excessive vomiting leading to tear of the esophagus, and the person will have be vomiting blood. So there could also be anemia because the person is not even taking enough, and a loss of weight and inability to function well. So hyperemesis gravidarum, as I have explained, is a time to support that woman emotionally, medically, and otherwise. Just note that with time, pregnancy is not a lifetime thing. So it will come to an end and you have a good outcome. Please, before you leave, subscribe to my YouTube channel. Follow my Facebook page. See you next time. I love you. Thank you. I remain your gynecologist obstetrician, Dr. Adazayon. Follow me at OBGYN Talks with Dr. Adazayon. God bless you. Thank you.